Welcome to VidZet, your home for careful consideration of our common concerns. I'm Dr. Ted Noel. Today, I'd like to welcome to VidZet Dr. Jeffrey Singer. He is a practicing surgeon in the Phoenix area, and he is a senior fellow at the Cato Institute and has written extensively on narcotics in terms of governmental involvement. Welcome to VidZet.
Thank you for having me.
All right. Now, the first thing that we have to ask in the discussion is what is an opioid versus what is commonly called a narcotic?
Well, narcotic, as you know, because you're in the field, is any sort of drug that could make you want to go to sleep or generally depress the sensorium. An opioid is a drug that is derived from the opium poppy. And out of those, there are two categories. There's opiates and opioids. People tend to use opioids to cover everything. Opiates are actually direct, natural derivatives of the opium poppy.
So the opioids are the synthetic ones. And
right,
the key is that they all act on a particular receptor to cause pain relief.
Correct.
Everything else they do is related to it. Yes. Now, when we look at opioids versus narcotics, in common parlance, narcotics, the term is very much bastardized to include things like cocaine, amphetamines, and so on.
That which makes no sense.
Right. Now, how many people die each year from opioid overdose?
Well, that is interesting because the CDC sometimes doesn't break down the numbers. The total overdose rate of drugs that they keep track of, and the most recent year they have data for, which is 2016, is roughly 64,000. But out of those, over 10,000 are from cocaine and over 7,000 are from methamphetamine. And then there's a smaller portion that's from benzodiazepines, or what people call
Valium-related drugs.
So, but out of the products that are either directly from opium or derivatives, opioids, out of the latest numbers, over 20,000 of the 64,000 were from fentanyl, which is a completely synthetic opioid. It's not.
Now, fentanyl is a drug I used by the gallon in my medical practice over 36 years, and we found it to be the safest opioid in the world.
Oh, it's an excellent drug, and it's widely used in the hospital setting, particularly, as you know, as a retired anesthesiologist. It's used for anesthesia. It's used in the recovery room. Critically ill patients in the intensive care units are often, particularly trauma patients. It's a great pain reliever for them. It's got a lot of uses in the outpatient setting. It's not used in the injectable form. The most common use is in the form of a patch, a skin patch. We're very small, absorbed over a few days usually through the skin, and that's not suitable for anybody who wants to use it non-medically. There's also a nasal spray and a throat lozenge, and there's a little tiny film that you can kind of put inside the corner of your cheek that slowly dissolves. These are, again, not suitable for recreational and non-medical use, and these are usually given to like terminally ill cancer patients, that kind of thing.
So if we look at the differences between fentanyl and heroin, morphine, Dilaudid, and all of the other narcotics that are out there, is there any fundamental difference between them?
Well, the difference is primarily in potency.
Okay. Now, that's a word that gets used like it's bad.
Well, no, it's not bad. It depends on what you're looking, what kind of effect you're desiring to achieve. So, for example, codeine, which is an opioid, codeine and morphine both derive directly from the opium plant. And codeine is probably the least potent of the opioids. In fact, in many countries to this day, it's available over the counter. And the way it works is it gets metabolized in your system to morphine.
Yep.
But a small proportion of it gets metabolized to morphine. The rest is basically discarded by the body. But that's the part that has the pain relieving effects. Then there's morphine. Then over the years, chemists and pharmaceutical companies have come up with, made some chemical modifications to enhance the potency. One of the earliest ones was diacetyl morphine or diamorphine, which was developed by the Bayer Corporation back in the 1890s, and they named it heroin from the German word heroisch, which basically kind of meant like super morphine. And it's about 2.5 times the strength of morphine. That's still available on the formularies in many countries around the world. They just call it by its generic name, diamorphine. It was banned in this country in 1924. Then there's dilaudid or hydromorphone, which is about 2.5 times the strength of heroin. That's legal all over this country, both in the injectable or oral form.
Yeah.
Then we go from there.
The key point I'm hearing is it doesn't matter whether I give you 10 milligrams of morphine, 5 milligrams of heroin, 2 milligrams of dilaudid, or some other dose, for example, of any of the other narcotics. As long as you calibrate the dose, they all have work on the same receptors to give the same kind of effect.
Yeah, but some also have different half-lives too.
Well, yeah. So the difference is really between the drugs are how much you have to take to get the result, the way you give it, whether you give it orally or by injection or through the skin, how long it takes to come on, that's the onset time, and how long it takes to go off, which would be your half-life.
That's pretty much it, yeah.
So in a sense, administered in the proper mechanical fashion, they're all the same drug.
Well, in a sense, yes. And as the clinician, a lot of it depends on what you're trying to accomplish. So, for example, when you're an anesthesiologist and you want to get your patient under anesthesia, you want something that works rapidly and takes a person very deeply down, like fentanyl. And that's why it's such a popular drug for anesthesiologists to use.
Now, when we talk about people who get overdosed, these are generally described as addicts. What is the difference between a physiologic addict and a psychological addict?
I couldn't get into, I think what you're trying to say, instead of physiological addict, I think what you really mean is a person who's physically dependent.
Yes.
I think that's a better term.
Exactly right.
Because there's unfortunately, many people, including most of the people who make policy, and I myself am guilty of this as well. We tend to use the word addiction very loosely, and we use it interchangeably with chemical dependency. You hear people say, I'm addicted to chocolate, I'm addicted to so the word addicted is used very loosely. But the fact is, many drugs, and of course, opioids are among them, can create a chemical dependency where this usually means you require increasing amounts to the same effect.
Your receptors get tolerant.
Right. And if you withdraw them abruptly after a prolonged period of time, you go into withdrawal symptoms.
That's called the abstinence syndrome.
Very, very, very painful, very unpleasant. So that's physical dependency. That's not the same thing as addiction. Addiction actually is a separate disorder that we're learning over the years has a genetic predeterminant, and as on a molecular level is different disorder. This is a disorder where you're craving the substance, you're thinking about your next dose while you're already on this one. You'll make a lot of destructive decisions about your life because you're obtaining that drug ahead of everything else. Even when you've been completely detoxed, you want to go back to it, which is why, for example, when heroin addicts are arrested and detox the hard way in prison, after they're released, which could be, sometime later, years later even, one of the first things they find themselves doing is looking for the person who can get them that heroin again. That's after being clean for a while. And of course, they have a higher overdose rate because they remember the last dose they needed to get the desired effect, but they lost their tolerance because they've been away from it, and then they tend to overdose and kill themselves. Yeah. But that's addiction. As opposed,
we'll get back to that overdose issue in a minute.
That's addiction as opposed to chemical dependency. Now, addiction, even as recently as 2016, Dr. Nora Valco, who's the director of the National Institute on Drug Abuse, has said that addiction is very rare among people given opioids in the medical setting, even among those with pre-existing vulnerabilities. Those are her own words. Now, we know studies going back to the early 1970s, but some even recently in the last few years, the Cochrane systematic analyses, a very, very rigorous analysis, highly respected by medical researchers, one in 2010 and one in 2012, looked at chronic non-cancer pain patients on long-term opioids. They found an addiction rate of roughly 1%. That's what was found back in the 70s. And then just earlier this year in the BMJ, it used to be called the British Medical Journal, a study done by researchers at Harvard and Johns Hopkins. They looked at 568,000 patients who were what they call opioid naive patients, which means they don't usually get exposed to opioids. And they were given opioids for acute post-surgical pain as a post-op painkiller, which is what the regulators are trying to stop us from doing. And they followed them over the years 2008 to 2016. These are all Aetna patients, so they were able to really they got into the Aetna database, and they used all of the diagnostic codes for misuse. There's a whole gamut of them, ranging from using it for something other than it was intended for to addiction. They found a total misuse rate of 0.6%. That's as recently as this January. But that's not news to people who are familiar with the subject.
So if we're talking about laws like the new law in Florida that said a doc cannot prescribe more than a 3-day supply of narcotics without some special rule that being met, that they're completely idiotic because 99% of patients are not affected, even though in the public literature they're saying all of these people are getting it from doctors, the pill mills, and trying to make it look like an 80% number that I've read in some places.
That flies in the face of everything we know. Now, a lot of them are basing it on the CDC guidelines that came out in 2016. Now, there are a lot of really respected experts in the field who think the CDC guidelines were flawed. But set that aside, even if you don't think they were flawed, this is what happens when politicians and bureaucrats try to do nuance. They can't do nuance. And science, at least clinical science, is a lot of nuance. So what that CDC study did, first of all, started off by saying, this is not meant to be prescriptive. It's meant to be voluntary. Our recommendations are based upon very limited information. A lot of it is just observational, anecdotal, and very limited studies. So keep that in mind. But you might, and we also expect that as a doctor, you know about your patient's situation better than anybody. So you'll weigh the risks versus the benefits. But here's what we think we know. Based upon what they call type 4 evidence, which is the least amount of evidence. It's mainly
I think it's this.
Yeah, basically, yeah. It could be. They said that most people who are given opioids for acute pain, usually 3 days supply is usually adequate. Certainly 7 days supply is more than adequate for most people based upon this limited amount of information we have. Well, as a clinician, you read this and you say, okay, well, first of all, you didn't tell me anything I didn't know, but I'll just kind of tuck that away in my kind of good to keep in the back of my mind list and continue practicing good medicine. But when a politician gets a hold of that, they say, oh, well, here's the answer to that, 3 days. So, for example, I think the first state to do this was Massachusetts. The governor there says 7 days and then you don't get addicted. So they passed the law saying you couldn't give 7 days. Kentucky did 3 days. My state now is going to be doing 5 days starting next year. Between now and next year, it's okay for us to addict everybody, but starting next year, we can't addict anybody anymore. So let's get them all in now. Actually, they put so many exceptions into the 5-day thing. I looked at it. I'm not sure it's going to impact too many people. But the point is that this is based on no evidence. And this is based on even the CDC, even if you think that they did a perfectly good study, the CDC told us practitioners, bear in mind, we don't really know this is certain. We're just kind of giving you suggestions. But that's all they needed to do to turn the politicians loose.
Just to refresh, that class 4 evidence is kind of, we think it makes sense. It's not based on any real data.
Exactly.
And the question then arises is, let's suppose you've got somebody who had a back surgery, they get a failed back, and now they're on narcotics continually. What kind of harm are those narcotics causing them, the opioids?
Well, unlike alcohol, for example, the long-term use of opioids, it does have some impacts on the body, but nothing that compares to alcohol. For example, no major organ damage. There's very inconclusive evidence that long-term it might impact cognition, but we're not sure about that. By the way, this is only in adults. There's evidence to suggest that it may actually damage some of the central nervous system in children.
Well, they haven't got a fully developed central nervous system yet.
We're talking about adults.
Mm-hmm.
Also, long-term use can, for example, lower your testosterone levels and estrogen levels.
Mm-hmm. Constipation.
It causes constipation. There are some rare disorders, for example, where you can get kind of a hypersensitivity to pain.
Yeah, but most of the time they're fairly benign drugs. And so we probably have a lot of people who are physiologically dependent out on the street, driving, holding down jobs and everything else, doing fine, that you and I don't even know about because they've had some medical problem that led to chronic pain and they're on the meds to manage their pain.
Absolutely. In fact, Rush Limbaugh was doing a great job on his radio show until somebody outed him about his physical dependence on hydrocodone.
Mm-hmm.
So, but yeah, just like all of us encounter people in our workplace who we suspect might be heavy alcohol users, except they show up sober, they do their job. We don't really know what they do after they go home. We don't really think it's any of our business, so we keep our nose out of it. But they're not bothering anybody. If they're doing any harm, they're doing it to themselves. And that actually is more dangerous to the body than people who are on chronic opioids for pain.
So if we look at chronic opioid maintenance, Portugal has done something interesting. They decriminalized all of the opioids, and anyone who is a certified addict is the term that I think they use, can get on a methadone maintenance program, which costs less than a latte a day. And they have the second lowest overdose rate in Europe.
I thought it was the lowest. I heard it was.
Well, the graphic I've seen puts them right at it, maybe one smidgen above the lowest. But the basic idea is the addict goes in, gets his methadone, he drinks it down, goes about his business, and he is maintaining. They also discovered that over a 10-year period, half of those people who were dependent dropped off the rolls, not because they died, but because they had worked their way down to lower and lower doses and weaned themselves off.
Yeah, I think also you might also be talking about the heroin maintenance program that started in Switzerland in 1994. That was the first country to do it. Because methadone maintenance, which is what's called medication-assisted treatment. There are also buprenorphine is another form of medication-assisted treatment. They have a significant dropout rate. So back in 1994, there was a very high number of IV heroin users in Zurich, Switzerland, in what they call Needle Park. They all congregated there. And the Swiss are very socially conservative, and they like a nice orderly central park. And so they decided to try something different. Since when you're on methadone and you take it orally, enough of it gets absorbed to block the withdrawal symptoms, but not enough when you take it orally to give you the euphoria that you get when you get heroin.
So you don't get a high.
Roughly the same amount of strength as heroin. It's about 2.5 times the strength of morphine. So what they thought is, since a lot of people are dropping off of the methadone and going back to using, let's try an experiment. So they started this program where, in order to qualify, you had to, number one, fail methadone maintenance. You had to be 18 or older. You had to be willing to surrender your driver's license, and you had to show up in their center. And you sign in. You're given a clean needle and syringe, and pharmaceutical grade diamorphine, which was available. And you inject in the presence of a healthcare professional. You sign in, you sign out. You can do that 3 times a day. And what they thought, maybe there'll be a better retention, because when they inject, they're getting that high, that rush they call it, that they're not getting with methadone. Well, what they found, here we are now, it's how many years since 2000? It's 24 years later. In fact, there even was a referendum years ago to end it, and the referendum went down to defeat more than 2-1. what they found is 20% of the people who started the program are still in it. They've had over 60% drop in street crime, a drop in heroin sales because obviously you didn't have to sell it. Plus, also a lot of the drug addicts were selling heroin on the street to support their habit. A drop in teen heroin abuse because when these people started looking like they were patients, it kind of didn't look cool, so kids weren't attracted as much. And a whole lot of people on their own, like you're saying, started as their life became stabilized and they weren't spending their day looking for the next contact. They got jobs, they got married, they got a more conventional lifestyle, and a lot of them on their own, once they got back to that conventional lifestyle, gradually detoxed themselves without anybody telling them to. And they've had zero overdoses because obviously when you're shooting up in the presence of someone who could save your life with naloxone, you're not as likely to die from an overdose. It's such success that they tried it in Germany a few years later. In Germany, 40% of people ended up getting jobs. They have it in Denmark. They have it in the UK, in Canada.
Okay, so basically the maintenance programs work. They reduce crime. They reduce overdoses. They cost very little. What's not to like?
They've had a dramatic drop in HIV and hepatitis.
Oh, yeah.
Drop in overdoses. Now, Portugal, on the other hand, in 2001, they completely decriminalized all drugs. And if you look at the statements from the people who were responsible for that, they said, we're not, quote unquote, throwing in the flag, throwing in the white flag on the war on drugs. We're going to try this as a different approach to address drug abuse. That's actually their attitude towards it. And what they found is, here we are, let me see, that was 2001. So in 2015, they reported a 75% drop in heroin addicts. Now they have an overdose rate of 6 per million. The United States has an overdose rate of 312 per million. And they have one of the lowest, in virtually all parameters, they've had a drop in drug abuse. Or at the worst, their drug, depending on the age category and the demographic, their drug abuse rate hasn't been any worse than it is in the rest of the European Union. For most categories, it's actually down, including teen drug use.
Okay.
So it's been such a success that Norway just decided to do it. So they're going to be implementing the program there.
Okay. Later on, we'll talk about why we should take that idea and follow it. But the question that now arises is intoxicants in general, because the opioids are used recreationally as an intoxicant, or they're used for people who are dependent and can't get them otherwise. If we're talking about intoxicants, everything I've read says that the percentage of the population that's wanted intoxicants of one sort or another has been relatively constant through millennia. Has that been your experience as you've looked through the literature?
Well, yeah, but I think there might be reason to believe, at least in the West, things might be on the increase. I mean, I don't know.
Okay.
We don't have data going back.
And if one intoxicant gets harder to find, are you stuck? Or can you go, say, from narcotics to alcohol to cocaine to methamphetamine to just choose something different?
It's just like when you push in a balloon, the air goes in here and comes out there.
Okay, so you have a lot of choices.
Our experience with opioids has been, according to the government, less than 25% of non-medical users even go to a doctor to get a prescription. So the majority are people who are non-medical users accessing drugs in the black market. As prescriptions have been dramatically reduced since 2010 and supplies have come down, they've just all moved over to heroin and fentanyl, which are now responsible for the great majority of overdose deaths.
Okay, well, we'll get to that in just a moment. But the question at this point is, we have had prohibition in the United States for on the order of a century, and we've ratcheted it up as we've gone along. And what does prohibition do to the price of the drug on the street?
Well, first of all, it makes it go up.
Okay. What do these drugs cost to produce if they're perfectly legal?
I couldn't give you the exact manufacturing cost, but I know that these are really cheap because even today, according to the CDC, the street price of heroin is 1/5 of the street price of a prescription opioid like OxyContin. So it's not that expensive.
Yeah,
And
the numbers I've read indicate that the actual raw cost of legal production for any of these drugs is less than the price for aspirin.
it might be so.
It's dirt cheap. And so if you were looking at legally providing the drugs, you'd have something like the Portugal experience where they spend about $4 a day to support an addict. And that includes the cost of the clinic and the paperwork and everything else.
I think Portugal. I think you're mixing up Portugal and Switzerland. Portugal doesn't do that. Portugal,
Okay.
Switzerland provides the heroin. Portugal doesn't have a heroin maintenance program. They just basically found a reduction because they're no longer arresting anybody. So what they've discovered is that drug users are no longer afraid to seek help when they want help because they're not afraid they're going to be arrested for committing a crime. So a lot of them have accessed the harm reduction programs like methadone maintenance, needle exchange programs, et cetera, that Portugal has decided instead of spending money on having cops on the street arresting these people and putting them in jail, we're going to spend money on making these harm reduction programs more available.
What I'm getting at, though, is the fact that when you prohibit something that people want, you introduce something that economists call a risk premium. And basically it runs like this, that I want it, and because it's not available somewhere else, there's somebody who's willing to provide it, but because they're running crosswise of the law, they're going to charge a premium price for it. And because I'm going to pay a premium price, I want a premium product, and you end up with a vicious cycle where you're competing and the prices go up. And the DEA reports this as a windfall profit for criminal enterprises. That's actually their language.
The DEA is helping these criminal enterprises profit by doing this.
And it's not peanuts. Where I read one number is on the order of $20 billion a year in the United States, something of that sort.
I'm not familiar with that number, but let me just tell you some other ways in which there's this risk premium. Number one, we heard President Trump say we need to make a death sentence for drug dealers. That's already a risk premium built into the into the business. When you're a drug dealer, you're more concerned actually about getting the death sentence from your competing kingpin.
Yeah, acute lead poisoning.
The U.S. criminal justice system. So if you've already gone into this business, you kind of work that into your decision, number one. Number two, another risk premium is that prohibition tends to make people who are dealing in the prohibited drug make it more potent, because you want to basically increase the return per volume of the substance. So, for example, during alcohol prohibition, they weren't smuggling in, beer and wine into this country. They were smuggling in whiskey. And drug prohibition, in the same way, leads to things like fentanyl being used to enhance heroin, so it could be brought in smaller amounts where more could be snuck in, and it can have more potency and draw a better price. Crack cocaine probably wouldn't have come into existence was it not for the fact that cocaine was prohibited, so that they came up with a way of making crack cocaine more potent.
So you could get more kick, more reward for your risk.
Right, and make it smaller too, so you can smuggle more in.
Right. If you look back in the history of the Vietnam War, we have a Laotian general, Uwana Ratakone, who ran an opium ring, and he sold branded heroin, 999 brand heroin. It was known purity, and it wasn't illegal to sell. I mean, obviously, getting stoned on duty, you suffered military consequences, but he competed on that. When his opponents in the commercial enterprise got purer stuff, he came up with WO Globe heroin, which again was a known purity. It was better stuff to compete, but nobody died from overdoses. They knew what they were getting.
Well, did you also notice that a lot of the soldiers who were using heroin in Vietnam, we heard stories about a lot of them coming back with, some of them, of course, were chemically dependent, but a lot of them weren't. It's not like we had this explosion of heroin addiction when the Vietnam War ended. Many of them, they used, because obviously it was their escape. They were not particularly thrilled to be in Vietnam. They used heroin and other drugs.
They wanted an intoxicant.
Right. It was their intoxicant of choice. And then when they came back to the world, as they called it, they stopped. Period. So again, this dispels this whole myth out there that, just one hit of heroin and you're addicted. Well, that makes no sense, because since heroin is just diacetylmorphine, then how come one hit of morphine or one hit of Dilaudid doesn't get patients hooked?
Yeah, they want their intoxicant. And because they had a calibrated dose, they knew they could take a hit, get drunk, so to speak, and they would recover and be on their way. Now, if we look at that now with prohibition, and we have the risk premium, you have competition between groups. What can a group A do to compete with Group B in providing more drug, better value for the user's money on the street in the U.S.? He mixes it with fentanyl.
Well, but they also do violence.
Yeah, but I'm just saying on the economic side, I've got better junk.
Well,
you come get mine, you get a better hit. The problem is now that you have an uncalibrated dose. You don't know what you're getting. And the overdoses are almost exclusively a result of uncalibrated doses.
Well, first of all, when you get it, that's one of my arguments why I think, decriminalization, like they did in Portugal and are about to do in Norway, is certainly much, much better than we have here.
Mm-hmm.
And it's easier to pull off, because technically you're not saying this is legal, this is good. It's just that you're not going to put people in cages for it anymore. So, yeah, that's definitely a step in the right direction, but it's not as good as legalization, because you still have to get it on the black market, so you don't know what you're getting. When I go into a supermarket to buy a bottle of liquor, and I see it says on the label 40% alcohol, it never even crosses my mind for a moment that, well, maybe they're lying to me. Maybe it's really 80% alcohol. Maybe it's got something else in it. I don't think about that, because it's legal. It's subjected to regulation. I could sue. There's competition. It's on the open market. Mm-hmm. So that doesn't worry me. But if I have to get something on the black market, I'm at the mercy of the guy who's selling it to me. I have to take his word for it. That's exactly how Prince died. We just learned recently from the medical examiner's report. He was a non-medical user. I think he hadn't obtained any prescriptions from doctors, contrary again to the narrative. And he liked to use Vicodin or hydrocodone, and he bought what he thought was hydrocodone pills on the black market. It turns out they were counterfeit hydrocodone pills, and they were made of fentanyl. And that's what he overdosed from.
So he got a massive hit he didn't expect.
And he stopped breathing. And that's what happens. That's what happens on the black market. That's why legalization is preferable to decriminalization, but decriminalization is certainly preferable to the drug war.
Right. But this is a key point, because so many news readers are reading this thing that fentanyl, it's so potent and people are dying of fentanyl overdoses, and fentanyl is thereby the bad guy, when in fact fentanyl is a very, very safe drug, and the bad guy is the prohibition. They're confusing a proximate cause with an ultimate cause.
Absolutely. Now, there are some people, again, there's been a rash of overdoses from fentanyl interestingly, among cocaine users.
Mm-hmm.
There was a big report in the Boston media about 6 weeks ago. A lot of people are mixing cocaine and fentanyl. I think it's to modify their their experience, and some are overdosing on the fentanyl.
Mm-hmm.
There's also, it's important to note that the overwhelming majority of overdose victims, in fact, upwards of 90%, are from polydrug use. Again, this is not the profile of a patient who's been given a prescription for a painkiller by his or her doctor. This is a non-medical user. So, for example, the latest numbers, the most recent numbers from New York City Department of Health, which keeps excellent statistics. First of all, they found 75% of overdoses in 2016 were from heroin or fentanyl. Out of that, 97% of them had multiple drugs on board. 40% of the time, one of those drugs was cocaine. Now, that's not the profile, again, of a person who's been given a prescription for, let's say, oxycodone for their post-surgical pain or for their chronic back pain. That's not the profile.
So basically, the medically administered narcotics are just simply not the problem.
Right.
It's
now,
a politician's excuse to do something.
That's part of it. Now, back about 10 years or more ago, there was a lot of media attention given to some doctors who were operating what's come to be called pill mills.
Yep, we had some in Florida.
Yeah, a lot of them. And there's no question these guys were, I'm sure as a doctor you would agree, these guys who were using their MD degree to basically be drug dealers, they were not ethical doctors, and they were arrested, and some of them were working in cahoots with pharmacies, and that got a lot of attention, and so that became an easy explanation. And there were some very powerful books written that went into detail about this. So suddenly an echo chamber developed between the policymakers, politicians, and the media, where they all everybody likes kind of a simple explanation, because when you got a simple explanation, then you got a simple way to fix it. So everybody locked in on that. And it's true, there were some of these unethical doctors, but this is the exception rather than the rule. And
for every complex problem out there, there's a simple solution that's wrong.
Exactly. And that's what I'm saying about the nuance.
So prohibition creates profits for the bad guys. It creates drug mixes which kill people because we don't know the potency. You don't have the experience with the drug to say, I know this one is safe for me. And it doesn't do anything good that we can see anywhere. Now, we've already followed the money to the drug dealers. Who else gets rich off of this?
The people in the criminal justice system do well. It funds police forces. It fuels, prosecutors' offices.
Forfeiture.
Agencies, asset forfeitures in the name of the drug war. Government agencies that would probably be a fraction of the size they are today, were it not for the fact that we're spending billions and billions and billions of dollars fighting this futile war on drugs. I mean, it seems like every week we hear in the news about the largest drug bust in history. Until next week, then it'll be the largest drug bust in history again. It's like you're in that movie Groundhog Day.
Right.
And that's where we're at. And what's so frustrating is that nobody, when alcohol prohibition was put into effect, it lasted about 10 years. And then everybody said, you know what? This turns out it was a bad idea. Let's just scrap it.
Mm-hmm.
But it's taken since Richard Nixon declared our modern war on drugs in 1971. They're still not even beginning to think, this is it was well intended, but it was a bad idea. Let's just.
I would suggest there's another beneficiary financially of this, and that's the rehab organizations, because now they're at the public trough saying, "Gimme, gimme, gimme! We're going to get all these people out of trouble."
I can't disagree with that at all. I think that is a factor. You see some of a lot. I don't want to. Obviously, everybody's different, so I don't want to generalize, but an awful lot of members of our profession who advocate continuing our current opioid policy, who happen to operate or have an interest in rehab centers.
Mm-hmm. This is the law of subsidy in action. Yeah. When you subsidize something, you get more of it. It gets more expensive. And the expense in this case is not only measured in dollars, it's measured in lives. And we're subsidizing the drug dealers. We're subsidizing the police and other parts of the justice system. We're subsidizing the rehab people by prohibition.
I agree. Also, another mistake that we're seeing, and this is policy that's being discussed in Washington now, because this is easy, throw money at something. So let's throw more money at making rehab centers more proliferate, build them, cover them. It sounds good, just like throwing more money at education. That'll get the outcomes to go up, right? Just throw more money at education. So I think I've been asked, what do you think about, putting more tax dollars into expanding drug rehab clinics? And I'd like to say that I call that the field of dreams approach. If you build it, they will come. That's not so much what the problem is. I mean, if we weren't arresting people and chasing them into the shadows, we would find that a lot more people would come forward and be less afraid
Mhm.
to ask for help and go to rehab because they're not afraid their lives are going to be destroyed by the criminal justice system, which is what they found in Portugal. But otherwise, as we know, addiction is a behavioral disorder, and one of the features of it is you crave it. There's a lot of denial involved in it. You think that you can quit when you want to, but right now you don't want to. And every time you think this will be the last time, you change your mind. So it's not like you have these heroin addicts in the street who, as they're putting their needle into their arm, they're saying, if it wasn't for the fact that there was a nearby methadone maintenance clinic, I wouldn't be doing this. They're doing this because that's what they want at the moment.
Yeah.
Just having more methadone maintenance clinics available is not going to make these people decide to throw that needle down and walk into the methadone maintenance center. So you have to, it's important that we reform our laws to make it easier to set up methadone maintenance centers and medication-assisted treatment programs, because a lot of the regulations have made it very difficult for these to be available to people. It's important for them to be available, but you're fooling yourself if you think just throwing more money at it is going to make more people go to it. First, you have to make them want to go to it. The old joke, how many psychiatrists does it take to screw in a light bulb? Just one, but how many psychiatrists does it take to change a light bulb? I'm sorry, I blew that one. Just one, but it's got to really want to change. It's the same kind of thing. An addict has to say, I don't want to do this anymore. I need help. But our laws right now are basically chasing them into the alleyways and away from them.
So what we need to do then,
let them not be afraid to come forward.
So ultimately what we have to do is recognize that all of the problems that we're seeing, or a large bulk of the problems, I won't say all, that would be overstatement, but a large bulk of the problems we're seeing, while they may look like it's heroin or fentanyl today, that's merely a proximate cause today, and that if we're going to change anything, we have to go backwards to the ultimate cause, which is prohibition, and recognize that there's going to be some portion of the population that we can't fix in either direction.
Always. In fact, here's an interesting factoid. Just at a recent conference in Atlanta, Georgia, about a month ago, a national conference on drug abuse that even Kellyanne Conway was a speaker at, it was announced that now they're worried about a surge in stimulant abuse like meth and cocaine. They're back on the increase. Methamphetamine overdoses are up 30% in the last year. So it's like a game of whack-a-mole. As soon as one goes down, the other one comes up. Back in 2007, the government cracked down on meth. 2005, I'm sorry, they cracked down on meth. They made Sudafed, which was used by meth labs to make meth, behind the counter, and they put a restriction on no more than 75 grams per month to a person. And aside from inconveniencing a lot of people who are, allergies,
got a cold or allergies,
the SWAT teams swooped in on the meth houses. So there was a slight drop for a short period of time. Then the Mexican drug cartel, the only thing they weren't selling in this country was meth, because there were so many meth houses in the United States. There was no niche for them to enter. So now all of a sudden that opened up. So then the Mexican cartel started smuggling in meth. Then 2 years later, the Mexican government made Sudafed impossible to get. So they found that if they use phenyl-2-propanone, or P2P, which was popularly used by bikers to make meth, they started using that to make meth. And so now they don't need Sudafed. So now we can't get Sudafed for our hay fever. But meantime, meth is on the increase, and it's all coming in from Mexico. So,
which brings up one more point.
Jobs to Mexico.
Which brings up one final point. If we were to decriminalize or legalize opioids and the other intoxicants, we probably would see no drug crime, that is, no drug cartels in Mexico, because they get their money from the U.S., and all of a sudden the things that they're selling for thousands and millions of dollars are worth pennies.
I think some of the biggest advocates of maintaining our hard line on the war on drugs are the cartel and their associates, because they hate to see this. This is how they're making their money. Back during alcohol prohibition, the mob was involved in bootlegging. As soon as prohibition ended, they went into drugs.
Mm-hmm.
That's what happens.
All right. Well, thank you very much. This has been a most enjoyable time, and hopefully the people who watch will have learned something, and we may start to make some inroads in putting a little sense in our legislators.
Thank you. It was a pleasure speaking to you.
Thank you, Dr. Singer. It's been a wonderful time with you this afternoon, and for those of you watching, please support us on Patreon, like us on Facebook, and follow us at VidZet on Twitter. Until next time, I'm Dr. Ted Noel.